Hey everybody, and welcome back to another episode here at Whiteboard Medicine. We appreciate you checking it out. Today we'll continue our shock series in talking about neurogenic shock. And within this episode, we're going to dive into neurogenic shock. We're going to talk about what it is, its mechanisms, key distinctions, classical presentations, pathophysiology, hemodynamics, oxygen consumption, how to differentiate it from spinal shock, some management principles, vasopressors, adjuncts, clinical pearls. We'll mention a couple trials, and then we got some practice questions at the end. So hopefully this is a nice whirlwind of kind of fundamental mastery of neurogenic shock. Before we dive in, though, just quick 30-second break. I'm going to bring you something we're really excited about. Don't go anywhere. Right after that, we'll dive in. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest Whiteboard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. All right, thanks for sticking around. So neurogenic shock is a type of distributive shock, okay? And we've talked about on this channel multiple times kind of the four different shock states. And these are kind of these umbrella terms we use. The first one being distributive, okay? After that, obstructive, cardiogenic, and hypovolemic. And these are kind of four shock state umbrellas that we commonly use when we're thinking about and learning about shock. And within the distributive shock context, there's septic, which is the most common. Okay, there's anaphylactic, another type of distributive shock. There's endocrinopathies, and then there is neurogenic shock. And even though we put all these under distributive shock, they all do behave differently. And that's why, siloing things I think is important for learning. But when it comes to actually mastering these different shock states, they do all behave differently, and that's important to note. So neurogenic shock is a type of distributive shock, and it's caused by a loss of sympathetic tone. You lose this sympathetic tone because these patients have a high spinal cord injury, usually above T6. And your sympathetic chain, the way in which you have sympathetic innervation, is above that. So when you have a significant spinal cord injury, most commonly above T6, you are unable to mobilize your sympathetic tone, and this can lead to shock. So the mechanism here is loss of sympathetic outflow. This leads to unopposed parasympathetic activity, and it results in things like hypotension and bradycardia. All right. Your sympathetic tone usually would cause vasoconstriction. You can't. You only have parasympathetics. You get vasodilation. This leads to hypotension. Your sympathetic tone would usually lead you to have tachycardia. You don't have that sympathetic tone. You only have parasympathetic tone. So you get bradycardic. All right. And this is somewhat unique among shock states. The vast majority of shock states, assuming you're not on a beta blocker, are tachycardic. But in neurogenic shock, you are inappropriately bradycardic. So hypotensive and bradycardic, which is somewhat classical. Now, it doesn't always work perfectly in the clinical arena. But on test questions, hypotension, bradycardia should be screaming neurogenic shock until proven otherwise. Key distinction here. So there is spinal shock, okay? And spinal shock occurs differently than neurogenic shock. Spinal shock, you usually are flaccid paralysis, no reflexes, sensory loss below the injury, okay? But you often do not have hemodynamic shock. You often are not hypotensive and not bradycardic. And we'll get into this differentiation a little bit more as we go on here. So the classic presentation of neurogenic shock triggers, you usually have a high spinal injury, so cervical spine or high thoracic spine. And that might be from trauma. Maybe you got stabbed. Maybe you got a fracture because you got in a car accident. That could be from tumor. Maybe you're compressing this area or have invaded this area. It could be iatrogenic, okay? Some, post-operative state. So cervical or high thoracic spinal cord injury is the trigger. And you really have to have a trigger. You can't really develop neurogenic shock without having that spinal cord injury. So you have to have a trigger. Most often, I think we think about trauma, but there can be other triggers too, but there's got to be a trigger. Vital signs here, like we said, you don't have sympathetic tone anymore. And that sympathetic tone usually vasoconstricts. It maintains your vascular tone. So you get a low SVR, a low systemic vascular resistance state, which for the sake of this discussion is equivalent with vasodilation. So you get vasodilation from your low SVR state, and that leads to hypotension. Your heart wants to get tachycardic when you're hypotensive, but in this case, you don't have any sympathetic input to the heart. You just have parasympathetic input or vagal tone. So that's going to lead to bradycardia. Remember that, bradycardia and hypotension. You often can get hypothermia too, because you can't really regulate heat as well. But the two main ones here are hypotension with bradycardia. Again, should be screaming to you, is this neurogenic? But again, you also have to have that trigger. You have to have that cervical spine injury. So on exam, you usually will have warm and dry extremities because you're vasodilated. You have low SVR. So those cutaneous blood vessels are vasodilated and it makes your extremities feel warm, right? Hypovolemic shock, cardiogenic shock, and obstructive shock all have cool extremities because they have vasoconstriction. Whereas distributive shock, septic, neurogenic, has vasodilation. So they have warm extremities. And you also should have neurologic deficits. If you've injured your high spinal cord, you might have paralysis, loss of sensation below the lesion. So you really should have neurologic deficits. We can't think, and someone correct us in the comments, but we cannot think of a patient who would have true neurogenic shock without any neurologic deficits. That probably doesn't exist. And if someone disagrees and it does exist, we'd love to learn from you. And then you probably will have absent reflexes. Spinal shock has some absent reflexes too, so there's some overlap there. But patients who are bradycardic, hypotension with warm extremities, and a neurologic deficit, neurogenic shock until you prove otherwise. The pathophysiology here we're going to dive into a little bit more. Again, this is somewhat repetitive with the beginning of the episode, but these types of things we feel if you cover multiple times in different frames can sometimes stick a little more. So as we said, the primary defect here is we're losing the sympathetic nervous system. Without the sympathetic nervous system, we get widespread vasodilation. And as we said, this is equivalent to that low SVR state. So decreased systemic vascular resistance and widespread vasodilation. We also have impaired cardiac stimulation because you don't have that sympathetic nervous system. In fact, you just have vagal or parasympathetic tone, and that's that bradycardia. So the hemodynamic cascade here is vasodilation from low SVR leading to hypotension. Okay, when you get hypotensive, you get some venous pooling because you cannot, when you get vasodilated, you get some venous pooling because you can't mobilize as much of that volume from unstressed to stressed to send it back to the heart. So you get increased unstressed volume, decreased venous return, more venous pooling. And then you get that unopposed vagal tone, that unopposed parasympathetic, leading to a decreased heart rate. So bradycardia, hypotension, venous pooling, warm, neurodeficit. All this to say the end result is a decrease in your mean arterial pressure, decrease in your preload, decrease in your cardiac output, and resulted tissue hypoperfusion, aka shock. All right. So when we think about the hemodynamics, this is more kind of test question helpful. We're going to talk about parameter and then result in neurogenic shock. Is it high or low? So your mean arterial pressure, although it can sometimes be normal and you could still be in shock, for the sake of questions and things, the mean arterial pressure in neurogenic shock is going to be low. You're going to be hypotensive. You're in shock. The cardiac output, is it going to be high or low? And this one might require a little more thought because in septic shock, the cardiac output is often high, but in neurogenic shock, that cardiac output is often low. And the reason being is because your cardiac output equals your heart rate times your stroke volume. And your stroke volume is going to be dependent on your preload. And we just said you get all this venous pooling, all this unstressed volume that's not returning to the heart. So you're going to have a decrease in your preload, and that's going to cause a decrease in your stroke volume. But unlike in other shock states, your heart rate cannot increase to compensate. You're going to remain with a bradycardic heart rate. So decreased heart rate, decreased stroke volume, secondary to decreased preload, which is because of the venous pooling and lack of venous filling, is going to lead to a decreased cardiac output. So in neurogenic shock, you have decreased cardiac output. What about your systemic vascular resistance, low or high? Well, hopefully this one makes sense now. Your systemic vascular resistance in neurogenic shock is going to be low because you're going to be vasodilated because you've lost that sympathetic tone. What about your central venous pressure, your CVP, the venous pressure filling the right atrium? Most likely going to be low because, again, we said you get venous pooling. So you get less venous return to the right side of the heart. So that CVP is most likely going to be low. It might be normal. It can be normal. So don't let that throw you off, but it's often low. And then oxygen consumption is a little more complex. We're probably not going to cover it in this episode, but we will in a future episode. All right, we wanted to then briefly differentiate neurogenic shock from spinal shock because this can be important. So neurogenic shock and spinal shock have a lot of overlap, but they are distinctly different, okay? Neurogenic shock is hemodynamic instability from loss of that sympathetic tone, whereas spinal shock is kind of a neurologic loss of motor, sensory, and reflex function below the lesion of the spinal injury. The onset is minutes to hours after injury for neurogenic shock, and it's immediate for spinal shock. The hemodynamics for spinal shock are usually stable, right? You're usually not hypotensive and bradycardic, but for neurogenic shock, you are. You're hypotensive and bradycardic. So that's one of the differences. Neurogenic shock, hypotensive, bradycardic, spinal shock, usually stable. Neurogenic shock, your skin is usually warm and dry, and that is because of the vasodilation leading to hypotension. So in spinal shock, if you don't have that vasodilation leading to hypotension, your skin, normal. Not a feature to think about. Skin feels normal. You're not warm. Resolution for neurogenic shock can be days to weeks. Spinal shock tends to, not resolve totally all the time, but usually improves over 1 to 2 days. Okay? So some differences there between neurogenic shock and spinal shock, just so that you guys know that there are two different kind of pathodromes related to shock states in the neurologically devastated patient. Management principles for neurogenic shock. Well, as with anything, airway and breathing, right? If the patient has a high cervical spinal injury, they might need to be intubated because they might not be able to maintain their own respiratory drive. So not necessarily specific to the shock state, although overlap there because high cervical injuries. Circulation for these patients. From a fluid standpoint, the hypotension is usually due to vasodilation, not to volume loss. So these patients often get some fluids, and it's probably reasonable to give them some fluids, but don't just crush these patients with intravenous crystalloids because it's not really a volume problem. It's really a vasodilation problem. And to help with the vasodilation, right, the treatment is vasopressors. So norepinephrine is often the vasopressor choice here. Norepinephrine is often a vasopressor choice in most shock states. Phenylephrine, people sometimes will use, and we've talked about all these vasopressors in our dedicated vasopressor episode, so just search Whiteboard Medicine vasopressors. We got tons of them on there that do deep dives on each one of these, because norepinephrine has both beta and alpha effects. Phenylephrine is all alpha, so this is all vasoconstriction. Again, we're not going to dive into all the nitty-gritty details of vasopressors, but phenylephrine as an alpha agonist does lead to vasoconstriction, which is what you want, but you sometimes can get worsening bradycardia because you can sometimes have kind of a reflex bradycardia that results with phenylephrine. It doesn't happen all the time, but because of that, we usually use norepinephrine, although phenylephrine wouldn't be unreasonable. Epinephrine can sometimes be helpful if there's severe bradycardia because low dose epinephrine, usually somewhere in the range of kind of 1 to 5 micrograms per kilogram, 1 to 5 micrograms per minute is usually kind of the chronotropic effect, chronotropy being increasing heart rate. So if you have severe bradycardia, sometimes low-dose epinephrine can be helpful. Bradycardia management, you can try atropine, doesn't always work. You can try temporary pacing, and sometimes these patients even need a transvenous pacemaker if you're having significant hemodynamic derangement from the bradycardia. Okay, so you have to address that heart rate because, as we've said many times, cardiac output equals heart rate times stroke volume. So I can put them on a vasopressor to try to increase their stroke volume, create some of that unstressed unstressed volume into stressed volume. But if they're still bradycardic in the 20s, we're still going to have low cardiac output. So you got to address both, increase that heart rate as well. Temperature regulation, just prevent hypothermia. Again, these patients can sometimes have some temperature derangements. Adjuncts here, we're not going to dive into much. They're more adjuncts related to spinal cord injuries, but people talk about steroids. They're a little controversial. And then spinal immobilization, urgent neurosurgical consult, all that stuff, address the underlying spinal cord injury. Hopefully people, intuit that naturally. So some clinical pearls here, and we're getting towards the end. Neurogenic shock is really the only state with hypotension, bradycardia, and warm extremities. So that's really something to note. And again, the clinical arena, things are more gray. So this isn't a hard and fast rule in the clinical arena, but on test questions, it certainly is. Now, some patients do have hypotension and bradycardia, right? You could have cardiogenic shock from a bradyarrhythmia, but usually cardiogenic shock has cool extremities, right? You could have obstructive shock from a massive PE that's causing you to be bradycardic. But again, usually you'd have cool extremities. So hypotension, bradycardia, and warm extremities is very classical for neurogenic shock. Make sure you distinguish it from hypovolemic shock because some of these patients are trauma patients. So these patients might come in as a blunt trauma and they might be hypotensive and you might be like, oh, hemorrhagic shock. But if they're bradycardic too, you really should be thinking about neurogenic shock as well in these patients. Early recognition and vasopressor support are critical. Fluids alone will not correct the underlying problem. And always suspect polytrauma if there's a high cervical spinal injury. Look for other injuries as well because it requires one heck of a mechanism to cause a high cervical spinal injury. So look for other injuries as well. We always put a little bit of literature on here. We usually don't deep dive on it, but we wanted to leave it here just so y'all have it. Some advanced trauma life support stuff on neurogenic shock. Some acute spinal cord injury stuff about maintaining a higher MAP. And then there aren't a lot of large RCTs specific to neurogenic shock, just as a FYI thing when we're thinking about the evidence-based approach to these patients. All right, into practice questions, and then we will be done with this episode. For those of you who have not done practice questions with us, the way we do it is we have a beginner, intermediate, and advanced level question. We'll read the question stem and the answers, and then we'll go right into the right answer. So if you need more time, make sure you pause the episode because we'll just dive right into the answer. So question 1, beginner level. A patient with cervical spinal injury presents with hypotension, bradycardia, warm and dry skin. Which type of shock is most likely? Given the name of this episode, you could probably get this answer without even reading the question stem. But nonetheless, A, hypovolemic, B, neurogenic, C, cardiogenic, D, obstructive. Pause here if you need to. Hopefully you don't. The correct answer is neurogenic shock. So independent of the fact that this episode is on neurogenic shock, what are the hints here? Well, one, they tell you the patient has a cervical spinal injury, so right there you're at risk. We also know they're hypotensive, bradycardic, and warm. This is that trifecta that should just scream neurogenic shock: hypotensive, bradycardic, and warm. So if it was hypovolemic shock, they would most likely be tachycardic and they'd have cool skin, right? If it was cardiogenic shock, they'd most likely be tachycardic and have cool skin. If it was obstructive shock, they'd most likely be tachycardic and have cool skin. Also, hypovolemic, cardiogenic, obstructive wouldn't tie into the cervical spinal injury much, so neurogenic shock. All right, question 2, intermediate. Which of the following best differentiates neurogenic shock from spinal shock? A, both cause hypotension. B, loss of motor and sensory function below level of injury. C, hemodynamic instability due to loss of sympathetic tone. Or D, pupillary changes. Pause here if you need to. The correct answer is C, hemodynamic instability due to loss of sympathetic tone. So remember, spinal shock does not have hemodynamic instability from loss of sympathetic tone. Okay, both of them do not cause hypotension. Spinal shock usually doesn't have hypotension. Both of them often have loss of motor and sensory function below the level of injury. And the pupillary changes is just a random thing. So hemodynamic instability due to loss of sympathetic tone best differentiates these two because in neurogenic shock you will have that. In spinal shock you don't typically. All right, C, advanced. According to the AANS CNS guidelines, what MAP target should be maintained in the first week after acute spinal cord injury? We maybe messed y'all up on this one because we flew through that literature, but A, greater than 60, B, greater than 65, C, greater than 75, D, 85 to 90. Pause here if you need to, or if you want to rewind the video to see what we wrote up there when we breeze through it. The correct answer is D, a MAP target of 85 to 90 millimeters of mercury. There's some argument here, there's some disagreement, but nonetheless, that's what we have in some of these guidelines. So, take it with a grain of salt. Don't take it to the grave. As we always say, none of this is intended to be acted upon as medical advice. The full disclaimer will be at the end of the episode, but we have some guideline coverage there. All right, that's all we have for you today. Hopefully you found that helpful, interesting, or intellectually gratifying. Hopefully that this can be helpful in the clinical arena or people's tests or learnings or what have you. And we'd love for you to check out our Patreon page or YouTube members page. If you prefer to listen to a podcast form, we also have this on all the podcast platforms. So let us know. Let us know what thoughts, comments, questions you have down below. And if nothing else, stay well, keep learning, and we hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.